Yeah, I'm not going to. Yeah. Oh, yeah, I know. I love the library. Yeah. My little Paul, yeah. G'day, hello. And just asked the concierge even if the mobile oh, nice. Yes. No, I'm just going to think about it in I don't think you understand. Nobody's playing. Oh, wait a minute. No?
Steve's there, yes, so we need to admit him.
Oh.
They've managed to get around it. The director.
Hi, Steve. Can you see us? Hello.
Yeah, how are you? Hi, Arthur, as well.
Steve, well, that's terrific. We didn't even admit you.
We might just put on the gallery view. Like,
Yeah,
Terrific. Okay.
oh, great. That's good. Yeah. Yes, my email. And you would have like last year. Yeah. I just come in and do your thing. Yeah. I you're doing one. We have some very good in the last 2 years. Yeah. Should I do that now?
Oh, yeah. They offered it. Yeah.
That's shared at the moment. So we can see.
It goes forward and back.
Yeah. Like this. Yeah. Yeah. It's more than my research. We are not
Gonna be
then I've got 3 days.
It's not a bad idea. I like it.
Yes, it's all they want.
I feel like once you broke the back of it, it's all right.
Somebody would. Yeah, Charles.
Well, thank you very much, everybody, for coming to the seminar today.
No, Brennan.
So this is the first seminar for 2025 in the Integrative Nutrition Seminar Series. It's terrific to have such a great audience, and it's terrific to have such a great speaker. These seminars will be running through the year, probably, roughly speaking, monthly intervals, and as time goes by, we hope that we'll be able to build this up and it will become yet another special community within the Charles Perkins family of communities, and also, of course, in the University of Sydney's family of research communities, and the integrative opportunities for research development and developing our ideas and ideas for new policies will also come out of this. For those of you who aren't currently on our email list, I've just left a piece of paper over on the side there with a pen. And if you'd like to join our email list before you head out this afternoon, if you wouldn't mind just providing your details, and then we'll follow up. I should also say that at the end of today's seminar, there will be a light lunch served out in the lunch area. So everybody is most welcome to join us for that. The Integrative Nutrition Seminar Series began last year. We had David Robenheimer and also an international visitor, Shin Takahashi from the University of Tokyo, and we're hoping to take advantage not only of the great speakers we have here in the University of Sydney family, but also nationally and internationally, and any ideas you might have for future speakers. Even nominating yourself is entirely appropriate for these seminars. So please think about that. I'll just mention a few names and then I'll come to Louise. So the steering committee currently includes Andrew Holmes, Anne-Marie Thau, David Robenheimer, Louise Baur, here with me, Margaret Ormond-Farinelli, Steve Simpson, and Tim Gill, and I'm also a member of that group. So those of you who are present today, it's great to see you, and thanks also for your ideas and energy and suggestions. In support of the group, there also is an EMCR support group, so early mid-career researcher support group, and many of them are here today as well. So thank you to Hiba, to Ashita, to Juliet, Alistair, Stephanie, who's our deputy chair today, and I'll come back to that in a moment, and Nick and Penny. So we do have people on Zoom as well, and while of course we really hope that people will be able to come to the seminars to generate the energy that you get from a room of people sharing ideas, of course it's not always possible, and so there are people on Zoom today as well, and Steve Simpson was one of those who wasn't able to be here in person today. We've decided to, in addition to having a chair, to have a deputy chair, and that person will be drawn from the early mid-career researcher group, and today's deputy chair is Stephanie. If I fall over, and as you can see, the older members of the community occasionally do fall over, then Stephanie will call 000 and she will step in to chair the seminar. She will also as I wheeled out, that's it. The show must go on. And Stephanie will also take charge, will chair the question session a little later in the talk. So let me talk now about Louise, because it's a great pleasure to introduce Louise. Louise and I have been friends and colleagues for a long time. We didn't realise this was going to happen.
Yeah, we started university together on the same day.
And we also became research students in the Department of Physiology together. So we have known one another a long time. But as is often the case, pathways go in different directions. Louise is a paediatrician and she's at the Children's Hospital Westmead, and she's in her primary responsibility is in child weight management, and you'll see that that's professional areas what's also driven her research interests. So there's a wonderful interaction between those two things. She's the Professor of Child and Adolescent Health at the University of Sydney. She's a previous head of the Children's Hospital at Westmead Clinical School. So she's also been very interested in education as well as in research and policy development. She's a member of the executive of the Charles Perkins Centre, and she's a past president of the World Obesity Federation, and she's the current president of the Australian Academy of Health and Medical Sciences. So it's a great pleasure to have you with us here, Louise. Terrific. And she's going to tell us about transforming, or trying to, the prevention and management of child and adolescent obesity. Welcome, Louise.
Thank you, Arthur. And hello, everybody. Hello, everybody. Great to be here. As I start, I'll just highlight my disclosures.
I may be the one falling over, can't I? I wish to acknowledge the traditional custodians of country throughout Australia and this land here, Gadigal land, our nation's first scientists with a great tradition of care for children and young people. And I pay my respects to their elders past and present and to Aboriginal people attending this meeting. I also want to acknowledge the many colleagues, students, patients and families with whom I have worked. I have some photographs of some of the colleagues over a good 20 years or so. I just thought, no, I look exactly the same there. Then I realised, oh, I'm not having to wear my glasses. I have changed over this time. And it's been a great group of people, an Australia-wide network, Australian Child and Adolescent Obesity Research Network, the NHMRC Centre of Research Excellence in the Early Prevention of Obesity in Childhood, several research teams, including the Fast Track to Health group, and of course, many people from the World Obesity Federation, and much more. Obesity prevalence is high, is a major issue in Australia, but also in our region and globally for children and young people. So the World Obesity Federation put out an atlas of childhood obesity some years ago and looked at the numbers of children and adolescents school age globally with obesity. So it looked at predicted numbers to 2030. And essentially there was recognised there was an increase over that time, and there was an estimated 160% increase in 10 years in epidemiologically in terms of this is just obesity. So where do these children and young people live? Well, here are the countries predicted to have school-aged children and youth living with obesity in 2030. So these are the ones with more than 1 million kids in 2030. And I want to highlight that China, India, USA, Indonesia, of the top 4, 3 are in Asia. Now, of course, those are countries with high populations, but it's not as if they're not seeing kids with obesity. So Asian countries very much affected. It's an issue, especially in middle income countries. And the highest prevalence, of course, you won't see it here because this one here is just about absolute numbers. The highest prevalence is in small island developing states, especially in the Pacific. So given this rising and high prevalence, there are strategies to both prevent and also to treat child and adolescent obesity. So I'm just going to give you a taste of some of the work in which I'm involved, and it's a bit of a perambulation, a bit of a variety. I want to start by looking at preventing obesity in early childhood. And you might say, well, why intervene in early childhood to prevent obesity? Why is that? Why is that important? I think it's important to realise that infant feeding, early diet patterns and sedentary behaviours influence obesity onset. So they're established early in the first year or two, and they tend to track, and they tend to track, and they tend to track. And as you can see from the right-hand side of this, obesity prevalence in under 5s has increased over quite a number of years. So you can see data from 1980 to 2015, and this is looking at obesity prevalence for 2 to 4-year-old boys. And you can see that compared with 1980, in 2015, there were more red or deep orange colours, including you can see the rise of obesity in China, the little emperor syndrome, not just high-income countries, but South America, Sub-Saharan Africa, and so on. I want to highlight that it's not just more common, but there's actually healthcare costs associated with this. In Australia, healthcare costs for 2 to 4-year-olds with obesity are 1.6 times higher than for kids aged who have the same age, but just with overweight or with healthy weight. So here's wonderful data from linked routine data linkage work that Alison Hayes led, looking at 2 to 4-year-olds. And what you can see here is that, particularly looking at the mode, that costs of hospitalisation were particularly driving, and as well as emergency admissions, were particularly driving the healthcare costs of 2 to 4 year olds with obesity. And they were tending to have respiratory problems and other things. So we know that this is an issue for adults. Or yes, adults have high healthcare costs to have obesity. Adolescents, school-age kids, well, this is the first one showing 2 to 4 year olds also have this. But, of course, you might be interested, but does early intervention work? Well, I want to present some of the work that I've been doing now for almost 2 decades with wonderful colleague Li Ming Wen, who's overseas at the moment, who's from Sydney LHD. After quite a bit of work in getting resources, he led the Healthy Beginnings trial, and has become a series of other trials as well. A staged, home-based early obesity intervention trial delivered by community nurses to first-time mothers from the end of the 3rd trimester to when the child was aged 24 months. This provided 8 home visits to pregnant women, once right at the end of pregnancy, and then 7 thereafter, most in the first year of life, to these new mums, and they were from southwestern Sydney, more socially disadvantaged area. And the key intervention messages were just standard health promotion messages for new mums. Breast is best, no solids for me until 6 months, only water in my cup, and so on. And the intervention effectively improved infant feeding practice and child BMI at 2 years. This is a randomised controlled trial. So what you're seeing here is actually the BMI distributions. Here in blue is the control group, and in red is the intervention group. So the intervention group received the 8 home visits, the others received mailed information about home safety, child safety, etc. And what you can see here, here's the BMI distribution, and don't get too concerned. You say, oh, a BMI, look at that BMI range. That's very different from adults. Yes, it is. Children are of different shape. Young children are of different shape from adults. And so you've got a different healthy BMI distribution. And what this intervention showed is that there was a shift to the left in BMI in those who participated in the intervention. Whether you did a completers analysis or an intention to treat analysis, there was a difference, a decrease in BMI at age 2 of those kids whose mums had participated in the intervention. And if we looked at the prevalence of overweight and obesity in this group, there was a decrease from 18% to 15% at age 2. We think, fantastic, we've done the right thing. We've also showed that there were differences in breastfeeding duration of those who actually received the intervention. So you see in the darker, in the red, the intervention group, and here's a survival curve analysis, and control group in dotted blue, and you can see there's a difference there. That was one of the interventions we were trying to focus. So we did see a mean reduction in BMI, and there were positive effects on infant feeding practices, vegetable consumption, not having food as a reward, TV viewing time. And there were some improvements for mothers in terms of self-reported outcomes. And we then thought, at this same stage as we were doing this, we thought, well, maybe we had recognised that there were some other Australasian trials underway. In fact, just after when Li Ming and I were setting up the study and we were planning it, we went to Australia New Zealand Obesity Society annual meeting. We went to the dinner. It was a good idea. We sat at a table with a whole lot of other really nice Australian early childhood obesity prevention people. And we said, oh, we're just starting this study. And 2 other people said, just heard, I've got the grant, it's under embargo, and I got it. And a guy from New Zealand said, and I'm just about to submit my grant application. And we said, let's see if we could combine the data from all the trials. And that therefore that is essentially established the early prevention of obesity in childhood collaboration. Now, this was us establishing that. There's already other work happening that was somewhat related. That all fed into the development of a Centre of Research Excellence in the early prevention of obesity in childhood, That was funded for 6 years, and then we've now, in the second last year, the next 5 years of funding, and this has been part of that work, and people from many different parts of Australia. What we did in coming together as 4 trials, I'll just highlight here, we've got the New South Wales Healthy Beginnings trial, the Victorian Infant trial, the Queensland South Australian Nourish trial, and the Prevention of Obesity in New Zealand trial. And all had outcomes, very similar outcomes being measured at about 2 years of age, somewhat different sorts of interventions. Ours was a home-based intervention, the New Zealand one had that as well, but there were others. Some used mothers groups and other things. And it takes a while if you want to say, well, maybe we'll come together and share our data and do this. We wanted to do an individual participant data, IPD meta-analysis. It's actually quite a lot of work to establish this, a lot of intellectual property, a lot of, here I'm handing over my baby, my data to this group of people to analyse. We've all got to agree on what primary outcomes are going to be and on the process. And I don't want you publishing the group data before my study is actually done. So fortunately, there are people who are really good at being able to manage these different sorts of personalities and issues. And we teamed up with the Clinical Trials Centre in doing this, and it's been a great collaboration. But you can see it takes a long time from first idea through to actually publishing your results in essentially in about 2021 from the first 2-year outcome data. So delayed gratification, sign of maturity, and you certainly develop that working in this area. So when we came together, and while we looked at these individually, we can also show the individual data here. There was, when we looked at them all together as an EPOC group, there was an improvement in this forest plot. There was an improvement in BMI or BMI Z score at the end of the intervention when we put them all together. Small, modest, but real. And there were also improvements in some diet and screen time behaviours as well. And it appeared that it was more effective in communities with little existing background support. But, it didn't persist. Without further intervention, the effects were not sustained out to age 5 years. So here's the BMI Z score over time for the 4 EPOC trials combined. And you can see here's the difference at age 2, but at 3.5 and 5 years, no matter how much you might try to modify and look at your statistics in different ways, no difference. That effect had gone. So why might there be a fade out effect? Question is, why do you think something that you do in the first year of life in such a busy, dynamic environment known as childhood should actually persist forever and ever? Well, we only intervened very early in life and not thereafter. And we did not change the broader obesogenic environment. The first year of life in particular, child much more cocooned. Even though it's more tricky for families, it's still relatively protected. Think about 3, 4, 5-year-olds, exposure to marketing, different environments and so on. Really, the big challenge is to address the upstream influences driving obesity. And while it's really important to think about early life, we need a broad life course approach, including but not limited to early life. And we need to think far more broadly, so from, in fact, pre-pregnancy, through infancy, early childhood, mid-childhood, adolescence, young adults, pregnancy again, families, workers, midlife, and so on. And if we're only looking at one little bit to change things, we'll run into problems. Now, of course, our CRE was growing. We had people who were excited, and we'd done this just in the, the Australia and New Zealand studies. And we wondered, and a group of EMCRs, or ECRs, very ECRs, linked to our CRE, were able to get an ideas grant to actually say, can we go global with this? We've trialled it on the Australians and New Zealanders, can we go global? And so the Transforming Obesity Prevention and Childhood collaboration was established with Lena Seidler and Kylie Hunter from Sydney, Britt Johnson from Deakin and others. And the aim was to bring together all the completed, planned and ongoing trials on childhood obesity prevention globally, looking at 2-year outcomes and doing quite detailed work around that. And so their approach, what they call next generation or new generation methods for data sharing and analysis. So the concept of IPD or individual participant data meta-analyses is instead of just getting, for example, as you see here in the schema, summary of that first study, all those patients there and giving a mean value, and then putting that together with the mean outcomes of the next one and so on, is that you get the individual data from all of those studies. So you get far richer analyses. But think about it. The interventions are actually quite complex. It's more complex, for example, than a particular drug at a particular dose versus a placebo. It's far more complex, these behavioural interventions. How do you support breastfeeding? How do you help parents to think about how they do or don't use food as a reward, how they change behaviour around food, how you cope with the challenges of screen time? So in this concept, you have the idea of deconstructing these complex interventions into components. And there's a whole array of ways of doing this that use, for example, TIDIA and BCT taxonomy. And I know I'm going to somewhat be rude to, no, don't mean to be rude, but just say somewhat obsessional people are really good at this, and some of us aren't quite as good at this. But I'm so glad for those somewhat obsessional, very hardworking people who do this work, but it has been an enormous amount of work. Now, the results from that, which has taken a long time, are not officially released as yet. We have a paper that's undergoing second revision, and the results are being presented for the first time at the Paediatric Academic Society's meeting in Hawaii the week after next. But I can tell you that they're going to be different from those original 4 Australasian trial findings. They're not going to find a dramatic difference. We're actually going to say it's not, when we put all of these together for many other countries, the later ones, we're not finding a difference. So there's a lot of things to think about that through there, and I can't talk to you further. I can't show you the data at the moment, but this is going to be something that's going to raise a whole lot of interesting reflections from us. It doesn't mean that what we've done already in Australia isn't worthwhile, but I think it tells you about the complexity of what's going on. Because we've also, in the existing trials, also further explored early childhood obesity prevention. And we certainly have some evidence of how to improve infant and early childhood feeding and obesity risk, not just from Healthy Beginnings, but from the other trials that have occurred. And how can we learn from those and deliver those sorts of interventions at scale? And so I have my lovely colleague, Lee Ming Wen, Rachel Laws from Deakin, Elizabeth Denny Wilson from Sydney Nursing School, and Concita Kuswara, who's a postdoc working as a knowledge translation coordinator for our CRE. And we recognise that there's limited evidence on how to implement effective early childhood obesity prevention interventions, or just infant feeding interventions in high-income countries at scale. And we're integrating 2 interventions into 2 different health services in 2 separate states. So Victoria and New South Wales have been very interesting places to work with, quite different experiences. And we're getting a better understanding of what works when scaling up. Now, so what enables proven interventions, in this case, infant feeding, early childhood feeding, screen time in kids, etc., to be scaled up? I'm going to give you just a brief overview because we've spoken to parents, to policy decision makers, to healthcare professionals, and essentially it's implementation science 101, and I've been learning this the whole process. So the evidence base needs to be highly regarded by health services. I work in a health service. I interact all the time with New South Wales Health. It's a big, messy, bureaucratic beast, and lots of different factors going on there. You need to align the intervention outcomes with organisational priorities. Is breastfeeding important? Is screen time important? Is ... important? You need to understand which intervention elements are flexible to adapt. Healthy Beginnings originally was a home-based intervention. You can only do that with high-risk families. We have actually adapted it for SNS and phone coaching environments, and we've had a look at that in other countries as well. And that's an example of something that needs to be trialled and then adapted. Home visiting won't work for the general population in our country, but SMS and phone coaching might work. You need to have a sustainable mode of trading because staff, the community nurses, healthcare nurses move on and need to be upskilled. You need supportive processes and you need organisational readiness for implementation. I'm talking about this. These are things, this is talking about 15 years after we have our original ideas, or almost 20 years. These are the sorts of issues that we're thinking about at the moment. I want to give you just a little bit of an idea about the sort of evolution of Healthy Beginnings. As I mentioned before, we actually ran the trial in 2007 to 2012. Part of it was done in 20 years ago. We've had the communicating it by telephone, SMS and phone coaching. We've done cultural adaptation work. There's been a lot of work looking at integrating it into existing services. There's current work looking at a web-based platform. There's a wonderful PhD student, Daniel Jawad, who's been looking at this, and including with Arabic-speaking families. And there's also work looking at developing a training program and a national nutrition service. And one of the people who's in this room, Eve House, is also another amazing PhD student working on this. So that gives you an idea of that work taste. But I want us to think beyond just early childhood. And there's some work that I've been involved with, which has been modelling the prevention of child and adolescent obesity across Australia. So this work was done with the Australian Prevention Partnership Centre, which had been funded by NHMRC for about 10 years or so, and I was involved with this. And we led this particular piece of work, Joanne Okapinti and Louise Baur AM and others. And the star, however, was Simon Chu, this former PhD student, who's a statistician at Hunter Medical Research Institute. Simon is an amazing person. It's very interesting bringing us very interesting working with different personalities, and I've loved this. The idea was to develop a national decision support tool to inform best buys for tackling child and adolescent overweight and obesity. I'm a policy decision maker. I've got to work out what are we going to do. We're going to do early childhood stuff. We're going to do sugar sweetened beverage tags. Do we do sports vouchers or something else? And this was developed as a system dynamics model. We brought together key experts and stakeholders. And we were particularly interested in these 5 interventions: the EPOC, early prevention of obesity in childhood ones, childcare service-based interventions, so that's more 2 to 5-year-olds, school-based interventions, sport vouchers, and sugar sweetened beverage tax / levy. So what this involves is that you have a conceptual mapping where you bring together a whole lot of experts, and then you get all that brainstorming happening, and then you give some poor bloke called a statistician, modeler, mathematician, and you put him in a room with a bit of computer grunt and say, go to it and do a computational model. And every now and then he will emerge out of there to say, I need some more information. Being a very interesting process. We then have a calibration and validation process, again informed by the workshop, where you reproduce historical data patterns, you refine the model, you go back, this iterative process. And then you come to the policy and intervention analysis, where you do the scenario testing and you build consensus for action. And in all the midst of this, you actually manage this during the COVID pandemic. Here's the example of our stakeholder participation. Yes, we use brown paper. Yes, we use Post-it notes. And Here's Simon at the back of this, looking like he's smiling. He's just realised how much work he has to do to try to bring this together. And what you can see here, this is an example of the concept map, very concept. So you've got around food and beverage consumed, change in BMI, physical activity, and a whole lot of other factors. You've got family characteristics, school environment, built environment, physical activity environment, in utero exposures, early childhood exposures, diet, food landscape, all important. And those of you familiar with other complex systems networks will understand that. And then you get a mathematician involved in actually working out how this might all work together and coming up with your behind the scenes computer modelling. And then you think about what that might mean. So I wanted to show you the results from this. Simon has published the actual development of the algorithms, the mathematical modelling, and just a month or two ago, we actually published in BMJ Public Health the actual policy analyses. So what you can see here is the results. Here we looked at from essentially from 2 to 22 years, the impact of changes in prevalence of obesity from baseline in the cohort followed for over 20 years. So this is modelling work, okay? And what you can see here is in green right at the top, and this is a change in prevalence of obesity from baseline. Well, early childhood obesity prevention, I already told you it was a modest impact, but it only works when you've got like an early childhood, and then we know that the effect fades for all the reasons I told you. Here are the childcare-based interventions. They seem to have a bigger impact. They start to come in particularly, and by the time they're, having their biggest impact about 5 or 6 years of age, but then they fade because that's when they will have stopped by then. We can see the school-based interventions having more of an impact in about 12 to 14 years of age. Sports vouchers, likewise. We can actually then combine just the early childhood ones up to 5 years of age here, and then we can also look at the combination of the adolescent ones. But when you put all 4 together in that sort of brown colour, you can see there's a bigger impact. But look what's happening in adulthood. Of course, it's waning because the intervention effect's happening. So we also looked at the sugar sweetened beverage tax or levy. Just to remind you, there are 100 jurisdictions, about 100 countries around the world that have a sugar sweetened beverage levy. Australia is a sugar exporting country. Neither Liberals, the coalition, nor Labor want to talk. I've been there to talk many times. It's just not on. It's politically tricky. So this is the impact of the sugar sweetened beverage tax. So this is the brown, shows the combination of all of the childhood interventions that we looked at. The black is the sugar sweetened beverage tax, and what you can see is that has a more persistent long-term effect, which makes sense because young adults are also, they modify their intake based on soda taxes and so on. And the intervention is going on because it's a much more universal intervention. So a sugar sweetened beverage tax was the best performing single intervention due to high adherence and exposure, and multiple interventions, or at least 4, over the life course of the intervention can replicate high exposure single interventions such as the sugar sweetened beverage tax. Now, we've developed policy briefs, and I've certainly presented this at national and state level to politicians. Interested, very polite, but it's a no-go area. But drip, drip, drip. Simon has made this amazing amount of work that he's done over this period of time publicly available. So there's an interactive interface for this national decision support tool. I think it helps if you've got a strong mathematical modelling background, but he's done a lot of stuff to make it accessible. Huge amount of work. It's like 3 PhDs in one. Good on Simon. Now I want to reflect further on the factors influencing childhood obesity. Hiba Jabali was the first author on this paper a few years ago, where we included the socio-ecological model for factors influencing child obesity. right at the middle of this socio-ecological model was the individual child. A lot of non-modifiable factors. There's early life or resilience factors, the family's knowledge, attitudes, and beliefs, or the young person's attitudes and self-efficacy and body image also there. You've got the family and peer influences, the socioeconomic position, family food security, the modelling of behaviours around eating and activity. You've got peer support and experience of weight stigma, all there. Childcare and school, physical activity, food environments. Got the broader community and built environment that include safe recreation spaces, walkability, public transport, the cost availability of foods, junk foods, etc. Broader society includes the media influence on food marketing, a lot of cultural norms. And then at the public policy level, you've got a whole lot of factors influencing agriculture, food, transport, and so on. You all know this. Now, most of the work that I've been involved with, most of the work that anybody has been involved with, has been at the level of the child and the family in their very immediate settings, because that's easier. We think it's easy, it's still hard to do. But where the big bang for the buck will be is actually tackling obesity beyond the sphere of the individual, family, and peers. So we need to think about how we move beyond that. And I'm happy to talk about some policy work later on. I want to now just change focus for a period from prevention to management. I've been involved in many studies. I'm a clinician working in the area of obesity management, and we've also involved quite a lot of studies as we've gone along. There's been group programs, intensive behavioural interventions, very low energy diets, drug trials, health services studies, etc., etc. We've also set up a service for children and young people with moderate to severe obesity. At the moment, a really strong interest, both clinically but also in terms of research, is when does treatment of obesity put a person at risk of eating disorder? Someone may want to ask me or Hiba later on why we became interested in this. That's a bit of group psychotherapy as well. But here, let's think about what about eating disorder risk when treating obesity in adolescents, or for that matter, adults? When should I be concerned about treating obesity in a person at high risk for an eating disorder? Can I recognise it? What if the treatment I provide inadvertently triggers an eating disorder? Should I avoid standard weight management approaches in such people? But if I do, don't they deserve access to some form of quality obesity treatment? What if they've got health complications? Don't they need that, for which weight loss might be important? And is dietary restraint necessarily a bad thing in an obesity-conducive environment? All really important questions. So, over a number of years, not just Hiba, but other people as well, led or took charge of a range of systematic reviews looking at psychological outcomes in children and young people who have been treated for obesity. And basically, the core message here is structured, professionally run obesity treatment in children and adolescents is associated with a reduced prevalence of eating disorders and disordered eating behaviours, a reduced symptoms of depression and anxiety, and overall improvements in body image and self-esteem. There's also been work done in adults, and this led by our same group. Why might this be the case? Why do professionally supervised programs, not, I might add, I'm a kid at school, I'll just do my own thing. We're talking about professionally supervised programs. Why might they be psychologically safe? A non-stigmatising supportive environment, structured and moderate dietary interventions, support for behaviour change, and frequent and often extended contact with health professionals. Same strategies you use in the treatment of eating disorders or of mental health problems. However, some people may be at higher risk of developing an eating disorder. So how can we identify them and support them and maybe modify treatment, personalise it? And are there elements of obesity treatment that may put some people at higher risk, such as regular weighing or calorie counting? Why do some people find that a risk and other people it's not an issue? seems. So it was in this context that two amazing postdocs, Natalie Lister, who's currently in Japan on holidays, and Hiba Jabali, who's in this room, developed the Eating Disorder in Weight-Related Therapy, or EDIT, collaboration. This was established in 2020 and is being supported by an ideas grant, but also by 2 investigator grants. And it is growing. So just to give you a concept of it, the aim is to phenotype individuals based on an eating disorder risk. We're not talking about genetic phenotyping, we're talking about the sort of thing you might do in everyday clinical practice. We're also looking at phenotyping the weight management interventions and assessing the interaction between them, because we want to optimise metabolic and eating disorder outcomes. And so, guess what? We're talking to a range, we have talked, a lot has been going on, to identifying the sorts of characteristics and individual components from experts and people with lived experience, which may contribute to eating disorder risk. We've collated data from a whole lot of studies, asked people to send their individual data to do this. There's been that individual participant data meta-analysis and even more complex intervention deconstruction. You can imagine that obesity management interventions will have quite complex elements in them. The predictive modelling has already started and there will be recommendations for translation. So stay tuned. But along the way, I think the bit that I found most amazing, that this process, these two amazing postdocs and the wonderful people with whom they've worked, have established a global community of researchers, practitioners, and people with lived experience across obesity and eating disorders. It's a safe place to meet. And I can tell you, it wasn't always a safe place to meet. You can ask us about that question later on. Now, I can't cover today work that I've done on the global advocacy work with World Obesity Federation, which has been such an amazing buzz. The Lancet Commission on the Definition and Diagnostic Criteria for Obesity. It's taken up a lot of my time the last few months. I'm involved with both the NHMRC and WHO clinical practice guidelines for obesity management. I'd love to have psychotherapy about how the challenges of delivering health services for people living with obesity in our health system. And there are a lot of interesting, challenging ethical issues encountered in the area of obesity. And I'm doing work in all these areas, but I can't talk to you just now. I want to finish with these key messages from today's very perambulating talk. Those next-gen methods for data sharing and analysis are useful in many areas. I've talked about them in obesity prevention and obesity treatment, but they've been used in many other areas. Fascinating areas, very time-intensive. We do need to keep a life course approach, including early life, but not solely. My view is that the commercial determinants of obesity and ill health need to be really addressed, and we haven't even started to try to do that. I think it's been really interesting to see the collaborative research across obesity and eating disorders, which are really breaking down silos and opening new insights. And overall, collaborative research is vital. I've given you some examples of that, but it takes time and resourcing. I want to, second last slide. Can we imagine a world? When we met together, World Obesity Federation last year, just thinking about our next few years strategy, we were really stimulated and inspired to think about the UN AIDS 3 zeros. So we adapted them, and I'm trying to use them frequently. So the 3 zeros for obesity, can we imagine a world where there is zero stigma towards people with obesity? There are 0 barriers to accessing care and 0 increase in prevalence. Question mark, things to consider. I want to finish by acknowledging funding and just the amazing groups of people I have worked with over a number of years. There's our EPOC website, and I want to say thank you. Stop sharing. There we go.
Thank you so much, Louise. That was such a wonderful talk. Do we have any questions? And we're happy to go to you, Steve. Oh, we've got one over here. Great, Andy.
Thank you, Louise.
And
I was just wondering, but is the concept of an obesogenic environment something that's actually recognised when you talk to government, or has it got a little bit of a poo-pooed?
I honestly think it's well recognised now, certainly at, certainly in talking to health department people, but when I normally give this talk, when I'm asked, what's the one thing you would do if you were in government to deal with obesity? I said, make it part of Prime Minister and Cabinet, take it away from the Minister for Health, who has no oversight of the drivers. So I think most people, anybody who's raised children, anybody who's struggled with their own weight, is aware of this obesogenic environment. I think there's only a very few odd people who normally looked after, but who aren't aware that it's a very obesogenic environment. I don't think it's too hard to get those concepts across. You just have to give a few examples. For example, I say, think about when you were a child, or when, depending on the age of people, and what's different now for children. Why is that the case? The world has changed dramatically.
Thank you, Louise. As always, very fascinating. Knowing what you know now, and looking at the list of countries in low middle income countries that are really going to be facing huge problem by 2030, what would be your most important recommendations to those countries?
The World Obesity Federation is working with WHO around this issue. That WHO has recognised that this is actually a major driver, if not the major driver, of NCDs globally, and it's largely been unaddressed. The WHO has a global obesity, let me just get it right, the Obesity Action Plan, and has 30 front-runner countries, about 6 in each, 5 or 6 in each WHO region, where they actually want to really do quite a bit of work. And when they talk to people in those front-runner countries, they wanted to deal with some of these big upstream issues. They also wanted to have some support for health services and training of health professionals, because they're dealing with so many people who have these issues, but they've also got to deal with trying to prevent it at the same time. So a lot of it's on these big upstream issues. So that's work that will take quite some time. And WHO is going to countries where there's a receptor site, where people are interested. The advocacy issue here is quite challenging. So WHO's approach, go to the countries that are actually interested, talk with them, see if you can involve NGOs like World Obesity Federation and others to build capacity and to identify people who can help. There's no simple answer here. And we're dealing with things like world trade, food trade policies and broader economic issues. And, just the last couple of months, we've seen how everything can be upturned, over which many countries have no control because of, what's happening in, say, the United States can have this big impact. So it's complex. That's what makes it so fascinating. But if I can just say one other thing, when I've been to WHO wearing my official hat, but I've been there several times, it's like obesity is everywhere but nowhere. The people in child and infant child health are interested in it. The people in NCDs are interested in it. The people in physical activity are interested in it. The diabetes people are interested in it. But it's never the top priority. So it's everywhere but nowhere. Exactly equivalent to what's happening here in New South Wales Health. It's everywhere in an LHD, but it's hardly being managed anywhere. It's not part of top planning or New South Wales Health Central either. So it's everywhere but nowhere. Nobody owns it. Like, people do own cardiovascular disease. People do own diabetes. A few pathetic people like me try to own obesity, but we have no power.
You just got a question.
Oh yeah, Steve.
Louise, that was beautiful. I was just wanting to pick up on your comment around the socio-economic influences, and the study that we were involved with Sally Cripps.
Yeah.
So the Ramsay funded study where we looked at the longitudinal study of Australian children with Sally and her Bayesian network modelling mathematicians, and how extraordinary it was to see the power of the socioeconomic on-ramp in relation to the less influential proximate influences of diet and screen time and the like. And those structural societal issues, which are very much part of that socio-ecological modelling approach, where perhaps we need to be putting more emphasis. What do you think?
Completely agree. Steve, you and I were co-authors on that paper with Sally Cripps, and it was one of the slides I threw out when I was, those things that I couldn't cover. But this was work using Bayesian modelling to actually look at potential causal pathways, effective pathways. And what was interesting was just seeing that time and again, multiple different forms of the model that came up, where you had low parental education, low family income, were actually drivers of whether this young person had obesity in adolescence. That was actually the major driver. It had its impact through physical activity and diet, but the actual on-ramps were everything to do with socioeconomic status, poverty, education, and so on. Highlighting, for example, the intervention to deal with this child should have happened 20 years ago when this parent was going to school or more. So just really, so it makes complete sense of what we broadly know, but it's just another example of how powerful this is, and how challenging to undo that as well.
Can I have another quick one? I was just related to the life course approach, which is a very powerful notion. And I wondered, is it as pessimistic as the influences at imposed at different stages fade, or do you think that they're able to at least increase the likelihood that the next step is in a healthier trajectory? So there's accumulating benefit, even though the intervention and its immediate effects have faded. Do you think there's a longer lasting effect?
I'd like to think that. It's really hard to get resources to actually follow up people long term, because of course there's a whole body of work suggesting that early life interventions can have these impacts 20, 30 years down the track. We were just showing, well, they weren't having the impact 5 years down the track, but maybe there are longer term benefits. I like to think that. I'm a paediatrician. I actually think this is a really, really important period of life. And sometimes just, I don't want everyone here to go and slit their wrists. I like to say, it's all over Red Rover by the time you're 18, but really important stuff is in young people. But I do think there are ways of modifying things. I mean, it's why you need interventions all the way along. And maybe that's the problem. We don't have interventions all the way along. We were just doing intervention that first year and a half of life and then expecting it to have an ongoing effect without having interventions multiply occurring. And that's the challenge, trying to work out how do we provide a supportive environment. I absolutely believe we've actually reflected on why did Healthy Beginnings have that impact, and I think it was in southwestern Sydney, more socially disadvantaged areas, and we think it wasn't unusually unusual intervention. It was good quality health promotion with new mums, but I wondered if we would have had that impact between the control and intervention group if we'd done it in Pymble or eastern suburbs, where everybody probably had access to good support. But where we did it, we did see that impact. But if we then gone and moved everybody to Pymble or eastern suburbs, maybe they would have had an ongoing difference, because they wouldn't have had that negative obesogenic environment continuing. I think that's a really important issue, and how do we follow that? Question mark. I think there's a question at the back here.
Sorry, I've got one, Louise. Congratulations on 25 years or more of really hard work. It was lovely to see it presented today. I'm actually going to raise the elephant in the room. And my concern is that society and politicians are going to adopt pharmacological approaches as they have with many other things like hypertension, etc. What do you think we can do to combat that versus doing something about the obesogenic environment, which is the real problem?
Can I just say, I love the pharmacotherapy. I prescribe it for my patients. Almost none of whom can afford it, but the hospital pays for it. I think it's really, really important. And that's why I talked about those 3 zeros. We need to address stopping stigma, decreasing barriers to accessing care, such as not being able to access good evidence-based treatment, but we also have to work on prevention. It's not either or, it's both, and we need to talk about it as both. Give the example of it's like providing great care for people for lung cancer and chronic obstructive airway disease and having beautiful health services, but still selling tobacco in the canteen at the hospital, which is what they were doing at Concord when I was a medical student. Next, and then you go and see all the old codgers with their sputum mugs beside them from their chronic airway disease. That was wonderful. Arthur wasn't of that experience. Anyway, so it's not either or, and we can't afford to have the treatment people and the prevention people at loggerheads. And we in World Obesity, like I'm one of those people really trying to get people to talk together and to go as one. That was what was happening with tobacco. And then we had people coming together with one message. We need to do that in this broader, but it's more complex than tobacco. So I'm happy to be part of that, and that's part of what we're doing in World Obesity as well. Happy to talk to people later on over lunch.
So we should wrap it up now. We've come to 1 o'clock, Louise. It's been a terrific experience, and to hear you talk about your experience of tackling this first world, but also general world problem. And to think about it in terms of both the health problem, but also in terms of an economic and political problem. And I'm going to ask you, once we leave the room, what you would like to say to the incoming Prime Minister of Australia if he was to give you an hour of his time.
Okay. I asked medical students to do that in my lecture yesterday, and I give them 2 minutes in the lift.
So please join me in thanking Louise. So thank you very much, everybody. If you would like to leave your name and email address, please remember to fill out the piece of paper at the back. And there will be a light lunch served around in the lunch area. So please stay on with us and have further chat about these interesting issues. But thank you.
And thank you, Steve, for joining at a distance.
Thank you, Louise. Brilliant. Thank you.